Hi, I'm Dr. Holly Russell, and I'm going to be presenting buprenorphine basics for opioid use disorder and pain. This is through the University of Rochester's MAT Access program. Our team has no ties to pharmaceutical or device industries. We have no financial, research, or clinical ties to specific treatment modalities. This project is part of the HRSA R-Core MAT Access 2 program, which is part of the Rural Communities Opioid Response Program and is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Our learning objectives today are to understand the risks of opioid use disorder, to describe the evidence for starting and maintaining a patient on medications for opioid use disorder, and to outline the basics of the medication for opioid use disorder pharmacology. First, we're going to take a step back and look overall at treatment options for opioid use disorder. The first bucket is pharmacotherapy, and we're going to discuss this much more, but this includes methadone, buprenorphine, and naltrexone. The second bucket that people think of most frequently is counseling. This often includes cognitive behavioral therapy, which can be done in individual or group-based therapy, or other types of behavioral therapy. Other options for treatment include risk reduction efforts. This may include access to clean needles, syringe exchange programs, or PrEP and PEP. We also have a focus on overdose prevention because we cannot treat people if they die, so we need to keep them alive. This includes fentanyl and xylazine test strips so people understand what is in their drug supply and making sure everyone has access to Narcan. And lastly, we're seeing more and more evidence for the use of peer support. This includes certified peer recovery advocates, as well as more traditional 12-step and mutual aid programs. In terms of an overview of the pharmacotherapy that's available for opioid use disorder, we're going to start with a note about terms. So as you heard in the name for this grant, it's the MAT Access Grant, and traditionally that was what we called pharmacotherapy for opioid use disorder. That term is falling out of favor primarily because it implies that the medication is not the primary treatment. It implies that the counseling or whatever else the patient is getting is the most important piece, and the medication is just there as sort of a secondary option. And now we have much more evidence to show that these medications are keeping people alive and that they are a primary and very important piece of the treatment. So our preferred term is the medications for opioid use disorder. You will very frequently still hear the term MAT, and some people will use that as medication for addiction treatment, which is another option. When you're thinking about which medication to use, you think about individual patient factors. The three types include agonist treatment, so opioid agonist treatment with methadone, opioid receptor partial agonist treatment with buprenorphine, which is often in combination with naloxone. The brand name for this is Suboxone or Zubsolv. And then opioid receptor antagonist treatment with naltrexone. The brand name for the long-acting injectable version of this is Vivitrol. Psychosocial therapy is also important, but not required for the mortality benefit from the pharmacotherapy. All of the guidelines now state that medication should not be withheld if behavioral treatment is not easily available, or importantly, if the patient is not amenable to it. There is an abundance of evidence for the use of these medications. Buprenorphine and methadone reduce the risk for opioid overdose by 38 to 59% compared to patients who are receiving no treatment or psychosocial treatment alone. Medication for opioid use disorder is associated with decreased all-cause mortality, including overdose, suicide, and other medical mortality, in a range from 6 to 25% in decreased mortality. The evidence shows that the longer patients stay in treatment, the greater the survival benefit, even if they have episodes where they return to use and then return to treatment. High rates of recurrent opioid use occur if medication for opioid treatment is discontinued prematurely. So we strongly recommend that patients continue on the medications as long as they are doing well. We know that these medications are underutilized. Despite the known benefits of MOUD treatment with buprenorphine or methadone, the rate of initiation is relatively low. In fact, some studies show only 12% of patients who need this have been initiated on the evidence-based treatments. We're going to switch gears here and talk about opioid withdrawal because it's very important to understand this when we think about buprenorphine, especially pharmacology. When patients are on opioids for any long period of time, physical dependence develops with continued use. Opioid withdrawal alone does not equal opioid use disorder. For example, anyone who is taking prescribed opioids every day will develop a physical dependence. The feeling of opioid withdrawal is often a primary driver for continued opioid use. And this is because opioid withdrawal is terrible. You'll hear patients describe this as being dope sick, and it is a feeling that is so, so awful that for most patients, this is the reason they continue to use opioids. It's not to feel good, it's to avoid feeling bad. And this is a graph that really shows this quite well. So in the acute phase, when people first start using opioids, you'll see they use them and they get that euphoric feeling. So this is what we think of when we think of people using drugs to get high. But what happens when people use opioids regularly, they develop this physical tolerance so that they actually, when they do not have opioids in their system, experience withdrawal. And they have to use the opioids simply just to feel normal. And this happens relatively quickly with daily use. So many patients will tell us that they spend their entire day just trying to avoid this terrible feeling, trying to get enough money to get some opioids to use so that they can get back to normal. And then when they get into withdrawal, trying to find more money so that they can find another opioid to use. This is where opioid agonist therapy comes in with buprenorphine and methadone. It helps patients get back to that normal feeling so it can free up that brain space and the time that they've been spending trying to avoid that withdrawal feeling. When you're assessing for opioid withdrawal, the tool that is recommended to use is the Clinical Opioid Withdrawal Scale, or COWS. And this is available easily online. And it's something you can do with a patient in your office. Some of it is objective in terms of the pulse rate, and some of it is subjective. For example, you do have to kind of notice if the patient's able to sit still. I often ask the patient how they're feeling in terms of kind of fidgety, and then some of it is like irritability. Again, I usually ask patients those ones that are a little bit subjective. Other ones are based on observation, like yawning. If patients are in withdrawal and you're not sure about starting medicines, as we're going to talk more about how to start buprenorphine, other things that can help and should be prescribed without any kind of worry or thought about safety concerns are the medicines that will help with the symptoms. So if patients are having a lot of nausea, we use ondansetron. For the anxiety and restlessness feeling, we often use clonidine as long as their blood pressure will tolerate it. We use hydroxyzine for anxiety or sleep issues, and similarly mirtazapine for sleep issues as well. These medications often are prescribed in conjunction with the medications for opioid use disorder or for patients who are otherwise going through withdrawal. Okay, now we're going to talk about the pharmacology basics for the medications for opioid use disorder. When we think about opioids in general, one thing that is important to understand is for most opioids, as you increase the dose, you increase the mu opioid effect. And this means that for most full agonists, and this includes morphine, methadone, oxycodone, almost every opioid that you can think of, as you increase the dose, you get a higher effect on the mu opioid receptor. And this respiratory depression effect related to increased mu opioid receptor activation is what is responsible for opioid overdoses. It results in a respiratory arrest. Different forms of medication for opioid use disorder work on blocking this phenomenon and also decreasing cravings for use. So as you can see here, buprenorphine is a partial agonist, and we're going to talk about that more in detail. And there are two different antagonists, naloxone and naltrexone. The major difference with buprenorphine from other opioids is that it is a partial agonist of the buprenorphine receptors, such that as you increase the dose, you reach a ceiling to the effect, so that increasing the dose further does not increase the opioid effects. This includes both respiratory depression and is partially true in terms of analgesic effect, although we're learning more and more about the analgesic effect, and we're going to talk about that a bit more later. Buprenorphine has extensive first pass metabolism, so it does not work well if it's swallowed. It has very poor bioavailability when swallowed. So all of the dosing mechanisms use other dosing mechanisms. Buprenorphine has a very long half-life of 24 to 36 hours. It has a very high affinity for the mu opioid receptor. So it will outcompete other opioids, and that's very important in terms of how and when to start buprenorphine. It requires a variable period of washout of other opioids to prevent a precipitated withdrawal, and we're going to talk about that in more detail. But you can see here, this is the mu receptor. And one thing that is so important about buprenorphine is that if you have it in your system, it's actually protective if patients were to return to use and use opioids such as heroin or fentanyl. The buprenorphine on the mu receptors will outcompete the heroin and will block the heroin from landing on the receptors. The opposite is true if they have heroin in their system before they start the buprenorphine. The buprenorphine will kick the heroin or fentanyl or whatever else off the opioid receptors, and it will, and that is what can result in precipitated withdrawal. So as you can see from this graph, remember buprenorphine is a partial agonist, so we're here at this kind of midway of the mu receptor activity. And heroin and fentanyl and oxycodone, all the others are full agonists. So if you're up here at the mu receptor activity and you suddenly get those receptors bonded to buprenorphine instead of heroin or fentanyl, you will have a very quick net decrease in the receptor activity. And this is what precipitated withdrawal is. And it is very uncomfortable and can, in fact, be dangerous if patients have other comorbidities like congestive heart failure or other cardiac comorbidities. So it is important when you're starting buprenorphine to understand what other opioids they have in their system and make sure they've gone through that washout period, or there are newer other ways to start that we're going to talk about as well. A question that often comes up is why buprenorphine is usually combined with naloxone. And that's because it's really supposed to it was developed to decrease misuse and was supposed to act as a deterrent. So when it's used as prescribed, either sublingual or buccal administration, there is minimal bioavailability of the naloxone. It really doesn't do much if patients take it as prescribed. However, the thought is that if patients were to dissolve the film and then inject it, that it would precipitate a withdrawal effect, and therefore it acts as a deterrent to misuse. In reality, buying a Suboxone film is much more expensive than buying fentanyl or other illicit drugs. So it's very rare that a patient would use their Suboxone in this way, and it does not seem to act like much of a deterrent. Okay. As I mentioned, it can be a little complicated to get patients on buprenorphine if they have other opioids in their system. So we're going to spend some time now talking about buprenorphine induction. There are four basic clinical scenarios to start someone on buprenorphine. One, they have no opioids in their system at all. This is the easiest one. You don't have to worry. You can start them on a low dose of buprenorphine and you can titrate up. You don't have to worry about precipitated withdrawal in this scenario because they have no opioids in their system. And you can start the buprenorphine depending on what their tolerance level is. You would pick a dose. If they have, a high level of tolerance, you might start at a medium to high level of buprenorphine just so that you don't have to spend a lot of time titrating. But really, it depends on what they're coming to you for. The second scenario here is if they've been taking full opioid agonists with predictable pharmacology. So this would be something like a prescribed opioid. Um, what you don't want to do is assume that if they tell you they're taking oxycodone but they're buying it from the street, do not assume that that is actually oxycodone. Most of the pills that are on the street now are pressed pills, meaning that they are made from fentanyl and then other things, and the drug dealers now can buy pill presses so that they press the material into something that looks like a pill. It even has the number usually on it. But most of the things that people are buying on the streets that say that they're oxycodone or OxyContin, most of those are illicit fentanyl and other illicit substances. However, so if you have a patient that you know what they've been taking and it is something with predictable pharmacology, like something that has been prescribed, and they take it long enough so that they are in mild to moderate withdrawal. And if you remember from that COWS scale, what you would do is go through those elements and actually count them up and add them up and give them a score to see where they were, whether it was mild to moderate. Anything kind of on the moderate end would be fine. That would be a scenario where you would feel comfortable that enough of the opioid was out of their system that you could safely start the buprenorphine. The third scenario here is if they have been using fentanyl or heroin from the street, and they have started to go through mild to moderate withdrawal. In this case, if you are new to using buprenorphine, I would generally recommend getting an expert opinion here from somebody who has experience, because what we're finding is that is very unpredictable what is happening with the supply, the drug supply nowadays, in terms of how long it would take for somebody to actually have to wait. And we've seen patients that have started to be in withdrawal and start buprenorphine and still go into precipitated withdrawal even after 72 hours. So generally, we used to say rule of thumb, wait at least 72 hours. If they had been using fentanyl, even that might not be long enough. So if you are new to this, we generally recommend asking for expert help if patients want to do this technique where they wait long enough where they're going through withdrawal. The last option, which is becoming the more common option, is to use a low dose or microinduction protocol, which you can use for patients before they go into withdrawal. So this is the case where patients have been using full opioid agonists, either prescribed or fentanyl or heroin from the street, and they want to start buprenorphine, and they do not have to wait any period of time. They can actually do this right away, and they do not have to experience any of those terrible withdrawal feelings. General dosing considerations when we're talking about buprenorphine or Suboxone, the combination, most times people end up on a dose that's between 8 to 16 total per day. Usually patients end up taking it twice a day, depending on tolerance and the indication. Lately, we've been seeing patients who need a higher dose, particularly if they've been using fentanyl frequently, they will have a higher tolerance. Also, sometimes for patients who are using it who also have a pain indication, sometimes and some tolerance built up from years of use of opioids, they might need a higher dose. Or if they have cravings that are not responding to the 8 to 16 milligram dosing. So we'd have people up to 24, even 30 milligrams, I would say. Um, for patients that have low tolerance, who have not been on opioids chronically, generally recommend starting lower in the 2 to 4 milligram daily dose range, particularly if there's any liver failure involved. Those patients, you absolutely need to start on a lower dose. Okay. Going back to our clinical scenarios, for patients who are on full opioids who are in mild to moderate withdrawal, you'll use the clinical opioid withdrawal scale. As I mentioned, if the patient is in the office or hospital, There is actually a self-opioid withdrawal scale, so SOWS, if patient is at home, if they want to wait until they're at home to start the medication. We used to do this more, I would say, when the drug supply was more predictable. Now that it is less predictable, I don't do home inductions as much. If the patient is in mild to moderate withdrawal, you can begin with a low dose of buprenorphine. When you have a predictable opioid, such as a short-acting opioid like an oxycodone, usually you only have to wait 12 to 16 hours for this to be significant enough withdrawal. If they're on longer acting opioids like the sustained release or extended release formulations, you'll need to wait at least 36 hours often for them to be in this amount of withdrawal where it's safe to start the buprenorphine. We have a specific protocol at the University of Rochester, which kind of goes through each of the steps. Many institutions have their own protocol. This is ours. We start with a 2 milligram film, watch the patient for 36 minutes to assure no precipitated withdrawal. If the patient is still uncomfortable, you give 8 milligrams. If they're still having symptoms, you can give another 8 milligrams in the evening after they go home. Generally, so that adds up to about 18 milligrams total on the first day. On day two, generally, again, most patients on average end up on 8 milligrams twice a day. Going back to the idea of the microdose induction or the low dose induction, this is again the idea for patients to not have to go through that uncomfortable withdrawal period. And the idea is that you're starting a very, very low dose of the buprenorphine and you're sort of sneaking it onto the receptors in a way that it doesn't cause a huge crash, but kind of, again, sort of sneaks it on over time while the patients are still using their other full agonists. So the important piece of this is while patients are building up the dose of the buprenorphine, they're still using their full agonist opioids. So if they were using fentanyl or heroin, they're still using that. If you were prescribing them something for pain, they're still using that, etc. So this is one very basic protocol. It's pretty straightforward in terms of you start with 2 milligram films and the patients have to cut it to get to the 5 micrograms. They take the very low dose 4 times a day. If you look on the internet for microdose induction or low dose induction protocol, you'll see there's a lot of different ones out there. What I have found with patients is that actually the specific dosing and regimen doesn't really seem to matter that much. It's really just starting with a very low dose and building up over time. And then the other important piece is that the full agonist has to be continued up until you get to about the 4 milligram every 6 hours dose. So after day 4, they would stop the full agonist. So again, with this technique, the microdose or the low dose induction, small amounts of buprenorphine accumulate at the receptor with gradual displacement of the other opioids, and the small doses don't seem to trigger a stress response that manifests as precipitated withdrawal. We've been doing this in my office for probably about a year and a half or 2 years now and have had really great clinical success with it. And the patients are very appreciative because it results in them not having to go through the withdrawal feeling. This is from a JAMA paper. It goes through different low dose initiation protocols. You can see this has sort of a version that's kind of similar to the one that I presented that we use. There's also a 7-day protocol. As I mentioned, I don't actually think that the specific dosing matters that much except for starting very low. I think it's just starting very low, building up gradually. And patients sometimes get worried about the cutting. And I usually tell them, like, it's not baking, the specific cutting doesn't matter, just starting with making sure you're starting with a small piece of the film. One alternative option to microdose is to use the buccal, and that is already only in microgram dosing. So you can use the buccal formulation and have people continue on their full agonist opioids and use the buccal film. This is a dosing regimen that's actually put out through the VA. So this is a VA guideline on chronic pain management. So this was a specific dose recommendation for patients that are switching over from full opioid agonists for chronic pain to buprenorphine. So just as this is just to let you know that this is available, and it's on the VA website. Okay, I do want to talk a bit about using buprenorphine for pain because that's kind of an up and coming area of interest. It's an an, a, an option that could be potentially be safer for many patients. First, we're going to talk about acute pain, and then we're going to talk about chronic pain. In general, for patients who have acute pain, so this would be if they're getting a surgery, etc. In almost all cases, medications for opioid use disorder, including buprenorphine and methadone, should be continued in all patients at all times if possible. So I always tell patients, like, whenever you go to the hospital, whenever you're, seeing other clinicians, please don't let them recommend that you stop these medications. Many clinicians don't have a great understanding of buprenorphine or methadone, and so may inaccurately tell patients that they need to stop. And it can result in, if you recall from the beginning of the presentation, it can result in a return to use. It can result in a relapse of their opioid use disorder. Really, the only time that medications for opioid use disorder should be held if patients are in the hospitalized or are having acute pain is if a patient is presenting with somnolence or lethargy. When patients are having a surgical procedure, we usually request that there's a discussion with the outpatient prescriber of the medication prior to any changes. Buprenorphine can be taken on the day of surgery. This is also an area of a lot of misunderstanding. It is sublingual. It is absorbed through the mucosa. It's not PO. So it's not swallowed. It does not interfere with anesthesia. Patients can and should take it on the day of surgery because otherwise what ends up happening is they may go into withdrawal while they are in the midst of their surgery, which would be quite confusing for the anesthesiologist. In general, we would prefer one prescriber should be managing the outpatient opioids and other controlled substances to avoid confusion and errors. So I usually try to communicate with the surgeon if my patient is having a planned surgical procedure to ask what they usually prescribe and let them know that I'll manage the pain. That can't happen if their medication for opioid use disorder is being prescribed in um, a specialty substance use disorder treatment program. Many times their license prevents them from treating pain indications. So often that's not a possibility, but if it is, it's ideal if one prescriber can manage both the opioids if needed to manage the acute pain as well as the medications for opioid use disorder. For planned surgical procedures, as I mentioned, we suggest that the surgery team contact the MOUD prescribing team to confirm plans and who will be managing the outpatient pain medication prescribing. Medication regimen, including timing of last dose, should be discussed with patient and confirmed with the prescription monitoring program. For complicated cases, we recommend consulting with specialists, so consulting addiction medicine consult service if that's available for you for questions or challenging cases. Another kind of area of lots of confusion is that it is okay to add full agonist opioids while someone has buprenorphine in their system. So it's okay to add on top of. Remember, the buprenorphine is a partial agonist and we're adding the full opioid agonist on top. That's okay. The risk comes from adding buprenorphine to a system which already has full agonist in it, and that's where we get that precipitate withdrawal. So it's okay to go up on that mu activity. What is dangerous is to go down on the opioid receptor activity. So if you can just remember that graph in your head, it helps kind of remember the order that it is safe. If patients are having planned surgical procedures or have other acute pain needs, there are several options for acute pain management. One is to continue the same dose of buprenorphine and just give it more frequently for reasons that aren't well understood. The analgesic properties of buprenorphine are improved with shorter interval dosing. So for example, if a patient was on 16 milligrams total, so 8 BID, you could split it and they could take half the dose 4 times a day, so 4 milligrams 4 times a day. You also can increase the total daily dose of buprenorphine. And like I said, it does have analgesic properties. So you can go up to 32 milligrams for short-term use. For small procedures, like for example, often for like a dental procedure or carpal tunnel release, that kind of thing, increasing the dose of buprenorphine is often sufficient. Um, we have also occasionally done where we would add buprenorphine, a low dose once a day PRN for breakthrough pain. This isn't a common recommendation, and I have only one patient that I have on this regimen, and he's actually on it chronically for some abdominal pain that he had been in the emergency room very frequently for. But giving him this like 4 milligram half a dose that he can use as needed has helped keep him out of the emergency room. Um, the issue with buprenorphine is because it's so long acting that you don't want to use it more than once a day as needed because the doses will stack, and you can end up kind of getting too high of a dose total. So once a day as needed for pain is a reasonable thing to try, but probably would not use more than one additional PRN dose in addition to their regular dose. Most commonly, for anything more than a small surgical procedure, we use full opioid agonists. And basically, what we do is we ask the surgeon what they usually use. The books say higher doses may be required for benefit, 1.5 to 2 times the typical dose. I have not found that to clinically be true. Usually, I just write what the surgeon requests. Or what the surgeon typically uses, and then I let the patient know to let me know if they need a higher dose. I will say that the thing that we do that I think is the most impactful is close follow-up. So whenever any of our patients who is on medications for opioid use disorder has a surgical procedure, if it is planned, we plan to have a telemedicine or phone visit with them as soon as possible afterwards, ideally the next day or the day after, so that we can check in with them about their pain. And I firmly believe that this is the most important intervention that we do because the patients know that they have FaceTime with us if they're uncomfortable. So much of the pain and worry that patients experience is related to, I believe, them not having access to us and having to go through phone tree if they're having questions, not knowing if they'll be able to reach anybody, not knowing if anyone will prescribe anything for them, if they are having pain, if they end up reaching somebody. And that creates a lot of anxiety, which, as we know, makes pain much worse. So my personal perspective on this is that having close follow-up is equally important as anything else we do. So I typically write the dose of full opioid agonist that the surgeons on average write for the procedure that they're doing. Let patients know they may need a higher dose, and I'm going to see them a day or two after, and I'll be glad to increase the dose if they feel like that's needed at that time. And I have almost never needed to write for the higher dose. And I think it's because they know they have that connection. Okay. Now lastly, we're going to talk about using buprenorphine for chronic pain. Again, this is kind of an emerging area of clinical use for buprenorphine. Again, as a reminder, buprenorphine has extensive first pass metabolism, so it is not available if taken orally. It's usually dosed sublingually, buccally, or transdermally. There's not a perfect equianalgesic conversion. Some sources will say 1 milligram bioavailable buprenorphine is approximately 75 oral morphine, but again, it's controversial. It's not an exact science in terms of the conversion. There is some guessing involved if you're switching people. The analgesic sublingual dosing is more frequent than what is used for opioid use disorder. So, for example, we would dose somebody who's using it for pain every 6 to 8 hours versus using it daily or twice a day for opioid use disorder. It's important that you know there's no randomized controlled trials on using buprenorphine for chronic pain. However, it's also important that I remind you that the same thing is true for full opioid agonists. So we have no randomized control trials showing that full opioid agonists, um, the evidence around them for using them for chronic pain. So the same thing is true for buprenorphine. And while we do believe there's a ceiling to the effect on respiratory depression, etc., in some clinical studies, they've try to look and measure this about the analgesic effect, again, not on humans, but they have not shown that there is a ceiling on the analgesic effect. So this is kind of an emerging area in terms of buprenorphine for pain. I present this just because it's kind of interesting how many different areas the buprenorphine works on. So while we talk about the mu opioid receptors, there are also multiple different receptors. The kappa receptor, the kappa opioid receptors, and that reduce tolerance. It has antidepressant some antidepressant characteristics. There's some also secondary analgesic from these other receptors. Again, just an interesting graph to think about all of the different areas where buprenorphine reacts. And if it's something that's interesting to you, I wanted you to know about this citation. This is an overview about the use of buprenorphine for chronic pain. You can see a summary of all of the different receptor effects. So the main ones are at that mu opioid receptor where it is a partial agonist, as we discussed at length. The analgesia, the dose-related ceiling effect. Again, it does have opioid overdose risk, but it's lower than with other opioids. Has some risk for tolerance and withdrawal, again, lower. It does have constipation. The risk of immune suppression and hypogonadism are less than with other opioids, and less of a risk of depression, suicidal ideation, dysphoria, and anxiety. And I'm not going to read all of these risks to you, but I just think it's very interesting about its unique mechanism of action and the safety profile as compared to the full agonist opioids. This is some more of the same, but want to make sure you understand some of these details. So it exhibits a lower incidence of constipation than is observed with the full agonist. Most of our patients do describe some constipation. Buprenorphine does not cause spasm of the sphincter of Oddi, and so may also be a preferred choice for pain and the management of biliary colic or pancreatitis. It may have better visual, psychomotor, or cognitive function as compared to morphine, methadone, or fentanyl. Um, as I mentioned earlier, the use of morphine and fentanyl is reported to reduce testosterone levels, while at high doses, buprenorphine does not seem to have an effect on sexual hormone levels. It is largely eliminated through bile in a non-renal pathway. So the levels of buprenorphine and its metabolite, as well as pain ratings, do not seem to change for patients on dialysis. And the drug is relatively safe in patients with liver failure. As I mentioned earlier, you would use a lower dose. I'm now going to present on the different formulations. Butrans patch is the transdermal form of buprenorphine. It has a specific pain indication. It's available in multiple different doses. You can actually use two of the 20 microgram doses concurrently for patients who don't get pain relief at the 20 micrograms. Um, you can kind of guesstimate which dose patch to use based on what their morphine mill equivalents are. If you're switching them over to this from a full opioid agonist. For opioid naive patients, you would start at the lowest, the 5 microgram dose, and try to titrate up. Because it is microgram dosing, it can be started without a withdrawal day period from short-acting opioids, although with some caution that precipitated withdrawal is possible. So for any patients with any comorbidities, I usually do have them wait for some washout period because I don't want them to go through that precipitated withdrawal, even though it is microgram dosing. And in terms of side effects, the most common one is skin irritation at the site of placement, and you can see it can be placed on the upper arm, upper chest, upper back, and side of the chest. As I mentioned, there's a buccal film. Belbuca is the brand name. This also has a pain indication and is microgram dosing. It's approved for use 1 to 2 times a day. This is an approximate estimation, so 75 micrograms is about 3 morphine milliequivalents. So again, you would do a guesstimate if you were switching somebody from chronic pain. For this, we usually would recommend a withdrawal period from short-acting full agonists, although again, may not technically be necessary if the pre-conversion morphine milliequivalent dose is low. Often the film requires prior authorization, but generally covered if there are some documented safety concerns with full opioid agonists. And the same thing is true with the patch. The sublingual formulations, the Subutex tablet is buprenorphine alone. This is generally the least expensive form of buprenorphine. So if patients are self-pay or have a high copay or high deductible, this might be the version you would use, the tablet form. It's generally relatively inexpensive, and there are like some of those online coupons available. It's available in 2 and 8 milligram dosing. It's has a pain and an opioid use disorder indication. You do have to do the withdrawal day induction or the microdose low dose induction. And this again is a rough estimate of the conversion factor. The film or tablet of the combination of buprenorphine and naloxone alone has only an opioid use disorder indication and is off-label for pain. It's okay to prescribe it for that. We write a lot of things that are off-label. It's available in 2, 4, 8, and 12 milligram buprenorphine dosing. The naloxone is at a 1:4 ratio of those. Again, not really important because it's not active if they take it as appropriate. The film is slightly more bioavailable than the tablet. And then typically you would do the withdrawal day start, but again, the microdosing is an option. As I discussed about as needed, the PRN dosing, there's really no high quality evidence to guide how to use it. It's pretty rare. The effect of when you take the buprenorphine to the peak effect is up to 90 minutes. So it's not the kind of medicine that you take and you feel better instantly. And then the peak plasma concentration from the sublingual dosing has a huge range, so from 90 to 360 minutes. And again, it needs to be longer that interval than from other immediate release opioids because of the concern about stacking doses and then theoretical risk of respiratory depression. Even with that ceiling to the effect, you still just don't want to get there to that risk. Um, Suggested intervals are 6 to 8 hours. I would not, again, do it more than once a day for an as needed dosing. In addition, if they were already taking it, a dose at baseline. This is a handout that we've modified from existing handouts that explains to patients about using buprenorphine for pain that I really like. I did not make up this magnet and light metaphor, but I really like the idea that the opioids turn the light fully on, but buprenorphine turns the light only partially on. So it's like a dimmer, and then naloxone doesn't turn it all on at all. But sometimes keeping a light bulb on too long burns it out. So that turning the opioid receptor only partially on has a lot of benefits. So I think this is a great metaphor and can be very helpful for explaining the use of buprenorphine to patients. And in terms of evidence, as I mentioned, no big randomized controlled trials. There are some smaller trials that actually have very good evidence around using this. So this is a small study and it was patients with chronic pain and opioid dependence. The patients showed much less preoccupation with pain. They expressed great satisfaction with the buprenorphine treatment. And in this second study, there were 35 patients with chronic pain who were previously treated with high-dose opioid agonist drugs, so did not have opioid use disorder, and were converted to buprenorphine. And you can see after 2 months, a huge decrease in their mean pain score. So small studies, but pretty convincing evidence. In terms of frequency of visits and monitoring, we always educate patients about need for safe storage, especially if there are children in the house. There is an overdose risk if children take buprenorphine, especially or anyone with no tolerance. We always discuss co-prescribing naloxone for anyone prescribed opioids We usually see patients weekly or every other week until their dose is stable. Once the dose is stable, the visits can be spaced out as you typically would for any other controlled substance. So I think that most practices do not need to reinvent the wheel here. You can treat this as you would for other controlled substances once patients are on stable doses. Getting patients on buprenorphine is a little complicated, but once they are on it, it's actually much easier than other opioids. And one of the reasons is it can be prescribed with refills. So it is a slightly lower level controlled substance. So you are able to prescribe it with refills. So patients can be seen every 2 to 3 months with refills, and you don't need to get that refill request in your box every month. In general, we check liver function tests prior to or right after we start patients on buprenorphine. I've mentioned earlier that patients with liver failure absolutely can and should be prescribed buprenorphine. It's safer than other opioids, which are all hepatically metabolized, but you just would use extra caution for sedation and start with a lower dose. No adjustment is necessary for kidney disease. We check buprenorphine and um, via this lab, which through the URMC lab is a quant as well as shows the metabolites. Usually there should be no or low levels of whole buprenorphine if the patients are taking it as prescribed. This top level here is the whole buprenorphine. If a patient has put the film in their urine, which does happen, this will show up as like greater than 10,000. So it's not subtle. It is pretty obvious when that happens. The challenge is if you're doing a dip in the office for buprenorphine, there's no way to distinguish whole buprenorphine from the metabolites. And so it will just come up positive for buprenorphine and you can't distinguish. We check urine drug screens. Most tests are tested through immunoassay, and you have to wait for confirmation to react to a positive result because many things can cause false positives. So that's just a reminder, do not react without waiting for the confirmation. In our labs, there is an additional drug section that I just like to point out to people because it has substances that are present that do not meet the cutoff for positivity in the immunoassay area. Um, this section does not get sent for confirmation, but the method for this section, if you'll notice at the bottom here, is liquid chromatography and tandem mass spectrometry, which essentially combines the physical separation capabilities of liquid chromatography with the mass analysis capabilities of mass spectrometry and is very sensitive and very specific. So while these do not get sent out for confirmation, you can essentially know that these substances are present if they are found in this section. So whatever your lab is that you're reviewing, it's important to understand which type of result it is. So in our labs, this result is an immunoassay, the top part, and this bottom piece is this chromatography mass spec um, uh, evaluation. And then an important reminder, because this is something that gets confused, is that the benzodiazepine immunoassays are often designed to detect nordiazepam, oxazepam, and temazepam, all of which are metabolites of diazepam. However, it often misses lorazepam and clonazepam, which have low cross-reactivity and are generally not detected on benzodiazepine immunoassays. So that can cause some consternation between patients and clinicians when they don't see what they think they're going to see. So that is essentially the summary. Please feel free to reach out to our team if you have any questions, and thank you so much for joining us today.